Welcome to part 6 of Therapy of Infectious and Parasitic Disease. In this section, we're going to talk about sulfonamides and trimethoprim. Sulfonamides and trimethoprim are broad-spectrum antibiotics. And although sulfonamide antibiotics have been largely replaced by more effective drugs that have fewer side effects, they still play an important role in treating certain conditions. Sulfonamide sulfomethazole in combination with trimethoprim is an antibiotic of choice for the empiric therapy of UTIs, or urinary tract infections. And the common use has placed sulfomethazole with trimethoprim among the top 10 most commonly prescribed antibiotics. This also says a lot about UTIs. Very common. So, key things here to understand are that they are bacteriostatic, they are broad spectrum, and when we think about these drugs, first we're going to talk about sulfonamides, and then we're going to follow by trimethoprim. Lastly, we're going to pull them together and talk about trimethoprim sulfomethazole, which is a fixed dose combination. They suppress bacterial growth by inhibiting the tetrahydrofolic acid, which is a derivative of folic acid or a derivative of folate. Sulfonamides were one of the first drugs that were available for systemic treatment of bacterial infections, and they were introduced in the 1930s, but even though they helped bring down the morbidity and mortality of susceptible infections, once penicillin was on the market and these now newer antimicrobial drugs, we haven't been using sulfonamides as much. But despite this, it does still have an important role in healthcare, and primarily it's against UTIs. Then when we started and we had available in the 1970s trimethoprim sulfomethazole as a combination, then we were now able to expand the indication for using sulfonamides. They're usually bacteriostatic, so accordingly, adequate host defenses are essential for eliminating the infection. They're more similar than they are different. So again, with this drug, instead of using a prototype, we're going to use sulfonamides as a group classification. The major mechanism of action has to do with the structural formula for sulfonamides, which you can see on this picture. Sulfonamides are the structural analogs of the para-aminobenzoic acid, or the PABA, a component of folate. This antimicrobial action of sulfonamides is based on this similarity. Remember that sulfonamides suppress bacterial growth by inhibiting the synthesis of tetrahydrofolate. Again, this is a derivative of folic acid or folate. And in the absence of tetrahydrofolate, bacteria can't synthesize DNA, RNA, and proteins. So it works because we are inhibiting this synthesis of tetrahydrofolate to then further synthesize DNA, RNA, and proteins. Now, if all the cells require folate, then how come these sulfonamides don't harm our human cells? And it all goes back to how with mammalian cells or human cells, how we acquire folate versus bacteria. Bacteria are unable to take up folate from the environment, so they have to synthesize it from precursors like PABA or tetrahydrofolate. But for us, our cells don't manufacture our own folate. We can take it from the diet using a specialized transport system for the uptake of folate. And because our cells use performed folate rather than synthesizing folate, the sulfonamides are not going to harm us. In addition to UTIs, there are some other uses. We can use it for chlamydia. We can also use it for conjugation therapy for toxoplasmosis and malaria, and oftentimes we're using it for ulcerative colitis. Sulfonamides have many adverse effects, and this is why many providers don't use it as a first-line treatment. There's actually a lot of patients that are allergic to sulfa drugs. There are prominent among these hypersensitivity reactions like Stevens-Johnson syndrome. It can also cause hematologic effects, kernicterus, especially in our newborns, and can also cause renal damage. Let's go back to these hypersensitivity reactions. Usually it's seen in about 3% of patients, and they tend to be mild, like rash, drug fever, photosensitivity. Those are relatively common. To minimize photosensitivity reactions, we will tell our patients, if you're on a sulfonamide, please don't go out in the sun. Prolonged exposure to sunlight can be detrimental, and we want them to wear protective clothing and apply sunscreen if there's no way that they cannot be in the sun. In terms of drug interactions, the metabolism-related interactions can also occur. Usually it's because sulfonamides intensify the effects of warfarin, phenytoin, and the sulfonylurea type oral hypoglycemics like glyburide. The principal mechanism is the inhibition of hepatic metabolism. So when you're combining sulfonamides with certain drugs, they have to reduce the dosage in order to prevent toxicity. There's also cross hypersensitivity. The theoretical concern is that people who are hypersensitive to sulfonamide antibiotics may also be cross hypersensitive to other drugs that contain the same sulfonamide moiety. And there are current evidence that demonstrates only a shared sensitivity among sulfonamide antibiotics, but not really the cross sensitivity to non-antibiotic sulfonamides. But there are some exceptions. There are drugs like azulfidine, which is an anti-inflammatory drug that breaks down into a sulfonylurea. And this is an antibiotic that's no longer available for prescription use. But because this isn't any concern now, do we need to even think about it? Well, experts still recommend precaution of severe hypersensitivity reactions to sulfonamide antibiotics, and they will actually put a label on it, warning people and telling patients to use it with precaution. So because of this, you need to also be thoughtful in how you are balancing the risks and the benefits. So again, one more time, only a shared sensitivity among sulfonamide antibiotics, but not a cross-sensitivity to non-antibiotic sulfonamides. With the sulfonamide drugs, we have to consider microbial resistance, and there are many bacterial species that have developed a resistance to this class of antibiotics, especially among the gonococci, meningococci, streptococci, and the Shigella. Resistance may be acquired by spontaneous mutation or can also be transferred by plasmids that code for antibiotic resistance. These are called R factors. Other drugs under the sulfonamine classification is sulfadiazine and methadone, and these are both used in patients with second and third degree burns to suppress bacterial colonization. Local application of methadone is frequently painful, where sulfadiazine is usually pain-free. Both these drugs have systemic absorption. Methadone, but not sulfadiazine, is metabolized to a compound that can suppress renal excretion of acid, which can cause acidosis, obviously, right, if you're keeping in the acid. And so therefore you have to monitor for acid-base balance pretty regularly. Sulfadiazine can actually cause this blue-green tinge or gray discoloration, so don't prescribe it for someone's face. Now we're going to talk about trimethoprim, which, just like the sulfonamides, suppresses the synthesis of the tetrahydrofolate, and it is active against broad-spectrum microbes as well. The mechanism of action specifically, it's through the inhibition of the dihydrofolate reductase, which is an enzyme that will convert dihydrofolic acid into an active form of tetrahydrofolic acid. And this will suppress the bacterial synthesis of DNA and RNA and proteins. We use this drug for acute and uncomplicated UTIs. And specifically, it is good at eradicating E. coli, protease, Klebsiella, Enterobacter, Staphylococcus, those type of UTIs. And it's only approved for the initial therapy of acute uncomplicated UTI for these susceptible organisms, but we can actually combine it with sulfomethazole, and this will allow it to have more applications, which we're going to talk about in a couple slides from now. Generally, trimethoprim is tolerated pretty well, but there are some adverse effects like itchiness and rash. GI things can occur occasionally, like epigastric issues, nausea, vomiting, sometimes glossitis and stomatitis. So just educate your patients to be aware that this may happen. The main things that you want to think about, though, are the hematological effects, the hyperkalemia, and use in pregnancy and lactation. First, we'll talk about the hematological effect. It actually can cause these are rare effects, but they can cause megaloblastic anemia, thrombocytopenia, and neutropenia, but only in patients that already have a pre-existing folic acid deficiency. So be careful in giving it to pregnant women, because we know what a decrease in folic acid will do and cause things like spinal bifida in the baby. And you don't want to give it to patients that have a excessive amount of alcohol intake. You also want to talk about the early signs of bone marrow suppression, like sore throat, fever, pallor. If your patients are exhibiting these things, they need to tell you, and you need to order a CBC. If you're noticing that there's a decrease in their blood counts, then you have to discontinue the medication. But additionally, you also have to give leucovorin, leucovorin, which is a reduced form of folic acid, because we need to restore normal hematopoiesis as soon as possible. With hyperkalemia, trimethoprim actually will suppress renal excretion of potassium, and therefore it's going to promote hyperkalemia, right? Because it's suppressing the secretion, the renal excretion. The patients that are at most greatest risk are those that are taking very high doses of trimethoprim, and those already with a pre-existing impairment of the kidneys. Also, if they're taking other drugs that are already elevating their potassium, like ACE inhibitors and ARBs, maybe even potassium-sparing diuretics or aldosterone antagonists, you shouldn't give this drug. Also, if they're on potassium supplements, it can also increase the hyperkalemia. Patients that are older than 65 and that are taking ACE inhibitors or ARBs, they're going to be the most at risk. And you can reduce this by actually checking their potassium levels. Preferably, you want to check about 4 days before starting the treatment, because the hyperkalemia is going to develop within about 5 days of starting the treatment. Now, in most cases, when you need to order an antibiotic, you really don't have, 4 or 5 days to think about that or to consider it. But you might want to keep it under consideration in case the initial antibiotic that you prescribe isn't what is indicated once sensitivities do come back. In terms of the effects on pregnancy and lactation, large doses of trimethoprim actually cause fetal malformations in animal studies, and developmental abnormalities haven't been observed in humans, but you just want to be careful because it does readily cross the placenta. So be very careful in prescribing this and avoid using it routinely in pregnancy. I would say only use trimethoprim if there's just absolutely nothing else. Okay. The risk for exacerbating pregnancy-related folate deficiency is something else that you want to think about too. So for me, in addition to the folate deficiency and also because it crosses the placenta, I don't prescribe trimethoprim to my pregnant and lactating patients. It also is excreted in breast milk, and it interferes with folic acid utilization of the infant as well. So breastfeeding moms, I don't prescribe this also. There's other things that we can prescribe that are safer. In terms of microbial resistance, bacteria can acquire resistance to trimethoprim in 3 different ways: by synthesizing the increased amounts of the dihydrofolate reductase, by producing an altered dihydrofolate reductase that has a lower affinity for trimethoprim, and then also reducing the cellular permeability to trimethoprim. And resistance here in the US is actually pretty uncommon, but the resistance results from spontaneous mutation and also from the transfer of the R factors. And lastly, we want to combine trimethoprim and the sulfa drugs. And so we will call this TMP-SMZ. And this combination will inhibit the sequential steps in bacterial folic acid synthesis, which makes it more powerful than just trimethoprim or the TMP or the sulfomethazole or the SMZ alone. So we combine it and we call it TMP-SMZ. And when we use this combination drug, it does come in different variations of the amounts or percentages of the drug, but it is a very powerful antimicrobial preparation. And the trade names that you're probably more familiar with are Bactrim or Septra. So the way this antimicrobial works is it inhibits the consecutive steps in the synthesis of tetrahydrofolate, but also the SMZ acts first to inhibit the incorporation of PABA into folate. And then the TMP will inhibit the dihydrofolate reductase, which needs to convert dihydrofolate into tetrahydrofolate, as we've discussed before. So the result of this is that the ability of the target organism to make nucleic acids and proteins, like the DNA, RNA, and proteins, is going to be greatly suppressed. By inhibiting the 2 reactions required for the synthesis of tetrahydrofolate, TMP and SMZ potentiate each other's effects. They play into one another. And so that's why it becomes more powerful, because they will come together and that sum of the effect is greater than just using trimethoprim or sulfomethazole by itself. It is also, in this combination form, selectively toxic to microbes because our cells use performed folic acid, right? So we're not affected by the SMZ. And dihydrofolate reductase of our cells are relatively insensitive to the inhibition that occurs by the trimethoprim. So in choosing this drug, we think about what does it cover. It's going to cover a wide range of gram-positive and gram-negatives, and it should not surprise us that TMP and SMZ by themselves are already broad spectrum. About 80% of urinary tract pathogens are going to be susceptible to this drug, specifically against Bactrim or Septra. Again, those are just brand names of TMP, SMZ. But consistently with those patients that have an E. coli acute infection or a Staph aureus infection, this even includes the methicillin-resistant isolates of that type of bacteria. And you can see among other ones that are listed on this slide as well. Now, the resistance to this combo drug is less than that to just having TMP by itself or SMZ by itself. And this is logical, right? It makes sense because the chances of an organism acquiring resistance to both of the drugs is less than just developing a resistance to one or the other. There are some preferred and alternative uses for this drug. Specifically, we can fight a variety of infectious disease, but again, we know it's very valuable for UTIs primarily. But you can also use this in otitis media, bronchitis, pneumonia that's produced by P. girovicii. And there's some other things, but basically, those are the more common things. Again, UTI being the most widely used indication. Adverse effects of this combo drug has to do with toxicity, but it's really rare. Usually this drug is pretty tolerated unless you already have a sulfa allergy. The most common adverse effect is going to be nausea, vomiting, and rash. They are infrequent, but you have to think about the serious toxicities as well. And this is usually with the sulfonamides alone or the trimethoprim alone. Okay, and if you are allergic to either of those things separately, you don't prescribe the combination. So just like the sulfonamides alone, we worry about when it's in combination to TMZ, hypersensitivity reactions like Stevens-Johnson syndrome. The blood reactions like hemolytic anemia, leukopenia, thrombocytopenia, aplastic anemia, and agranulocytosis. We also worry about kernicterus in neonates and renal damage. And with trimethoprim in combination, just like by itself, we're worried about megaloblastic anemias, especially only in patients that already have a folate deficiency. We're looking for hyperkalemia in patients that are taking this in high doses or have renal impairment or on drugs that can cause potassium levels, which we discussed previously. Now, this combination can also cause adverse CNS effects like headache, depression, and hallucinations. And patients that are dealing with AIDS are usually susceptible to toxicity from this drug. So in this group, the incidence of adverse effects is actually about 55%. And 55% of them will get rash, recurrent fever, and leukopenia. So think about that as well when you are prescribing this drug. Now, there are some renal issues associated with TMP-SNZ, and we will see crystalluria. And if you see this, you want to avoid using this medication. Now, there are several measures that can help reduce the incidence and the severity of this. And if we can maintain adequate hydration, we reduce the risks of crystalluria. We can also have periodic blood testing, permitting early detection of the hematological disorders. And in order to avoid kernicterus, we would not give this patient, a pregnant patient, this medication near term because we are putting risk for their neonates. We're not giving it to nursing mothers because it crosses through the blood or the breast milk, and it crosses through the placenta. We don't want to give it to anybody under 2 months old. To avoid possible birth defects, we don't give this drug during the first trimester. And if you can avoid it altogether, that's even better. The risk for megaloblastic anemia can be reduced if you don't give sulfonamides to patients that already have a folate deficiency. And I know I'm repeating some of this stuff, but it's really important that you understand this and that you are prepared to educate your patients on this. Because most people think, well, if you're not allergic to sulfa, then it's okay. But really, there's a wider range of reasons why you wouldn't want to give this drug. Additionally, something that I do want to bring up that we did cover when we talked about sulfonamides, but just as a reminder, anyone that's on a thiazide diuretic or a loop diuretic, anyone that is on a sulfonylurea type oral hypoglycemic agent, they should not, they shouldn't consider this drug also because there could be a hypersensitivity to it too, or if they just have general hypersensitivity to sulfonamides. How would we check for hyperkalemia again? Get a serum potassium and to see if there's an elevation. This last section for this week is about drug therapy for urinary tract infections. UTIs are the second most common infection, especially in sexually active young females and older adults, usually living in institutional nursing homes. It is less frequent in males, but we do have some occurrences. And, when they're associated with complications like septicemia and pyelonephritis, it is increasingly worrisome. But there are several classes of antibiotics that we can use to treat UTIs, and among them are the sulfonamides, the trimethoprims, and the penicillins. Also, there are 2 urinary tract antiseptic agents that we're going to talk about as well. So they don't actually fall under the class of antibiotic, but antiseptics. And these are nitrofurantoin and methenamine. And the basic pharmacology of these drugs we're going to talk about in just a little bit. Now, as a reminder, with the pathophysiology of UTI, we know that infection can be limited to just bacterial colonization of the urine, or bacteria can actually invade into the tissues of the urinary tract. When they invade, you will get characteristic inflammation, cystitis, urethritis, pyelonephritis, and prostatitis. UTIs can be classified according to where they're located: upper urinary tract, lower urinary tract. When you think about the upper urinary tract, you're thinking about kidneys. When you're thinking about the lower urinary tract, you're thinking about the bladder and the urethra. But within this classification, cystitis and urethritis are considered lower urinary tracts, and pyelonephritis is an upper urinary tract infection. We can also classify it as either being complicated or uncomplicated. Complicated UTIs happen in both females and males, and they're associated with some underlying predisposing factor. Like maybe there's a renal calculi, or maybe the male has a prostatic hypertrophy. Maybe they got it from an indwelling catheter, or some type of physical obstruction of urine flow. With uncomplicated UTIs, again, primarily happening in women in childbearing ages and not associated with any particular predisposing factor. If you've had a history of UTI and chronic UTI, you may have gone through some of these classes of antibiotics, and you may be on a prophylactic antibiotic. But these are the ones that are the most common. Among the sulfonamides, trimethoprim, penicillins, we also have aminoglycosides, carbapenems, cephalosporins, fluoroquinolones, and again, the 2 urinary tract antiseptics. Do you remember what those are? Nitrofurantoin and methenamine. So, with the exception of the antiseptics, we've already talked about the drugs in the other chapters. So we are going to spend more of the time talking about the antiseptics here. So organisms that cause UTIs in the first place: E. coli is the number 1 offender. About 80% of uncomplicated community-acquired UTIs are caused by E. coli. Rarely other gram-negative bacilli like Klebsiella, Enterobacter, Protease, and Pseudomonas species are going to be the cause, especially if it's their first UTI. Gram-positive cocci, especially Staphylococcus saprophyticus, will account for 10 to 15% of community-associated infections. So it's very low compared to E. coli. Now, hospital-associated UTIs are frequently caused by Klebsiella, Protease, Enterobacter, and Pseudomonas, Staphylococci, and Enterococci. But E. coli is still responsible for less than 50% of these infections that happen in the hospital. Now, most UTIs will involve only one organism, but sometimes you might have multiple organisms, especially if it's a patient that has an indwelling catheter, or someone that also has a renal calculi, or has a history of chronic renal abscesses. The most common treatment of choice in adults for oral therapy of UTIs is going to be nitrofurantoin or Bactrim or Septra, which is the TMP SMZ. These are going to be the first and second line treatments. And we've already talked about TMP SMZ, so we're going to talk about nitrofurantoin. At low concentrations, it is considered bacteriostatic, and in higher concentrations, it is bactericidal. And both nitrofurantoin and methenamine are used only for urinary tract infections. So this is important also that maybe you didn't know. And the drugs become concentrated in the urine and are active against common UTI pathogens. But neither of these drugs are effective in terms of trying to fight infection in the blood or the tissues. Nitrofurantoin is considered the first choice drug for uncomplicated cystitis. So you might remember this or have heard about nitrofurantoin as being called macrobid, macrodantin, furidantin. Those are the most common brand names. It's a broad spectrum antibiotic, and it produces a bacteriostatic effect in low concentrations and a bactericidal effect in high concentrations. I do want you to remember that, and this is why I repeated it twice. Now, therapeutic levels are achieved only in the urine, and nitrofurantoin can cause serious adverse effects, but usually it is generally tolerated. The effects that you would see are GI, pulmonary reactions, hematological effects, peripheral neuropathy, hepatotoxicity, and even birth defects. And we'll go into that more, but let's first talk about the mechanism of action. It will injure bacteria by damaging the DNA of the bacteria. And however, to damage the DNA, the drug must first go through an enzymatic conversion to achieve a reactive form to fight the bacteria. Nitrofurantoin is selectively toxic to the bacteria because, unlike our cells, bacteria has a relatively high level of enzymes that are needed for drug activation, which we do not have. So we can't activate it against ourselves. It is active against gram-positive, gram-negatives, especially E. coli. You can see in your chart in the book and in the last slide the other organisms that it can work with. Indicated for acute infection of the lower urinary tract that's caused by those susceptible organisms in the last slide. And it can also be used for prophylaxis for recurrent lower UTI. I like to use nitrofurantoin as a prophylaxis as well. It's not recommended for infection of the upper urinary tract, so you wouldn't want to use this for pyelonephritis. Okay, so now getting into the adverse effects in a little bit more detail. What are the GI effects we're talking about? Loss of appetite, nausea, vomiting, diarrhea. Those are the main ones you'll hear, but they can be minimized if you ask your patient to take the medication with milk or with meals. If we reduce the dosage, this can also help as well. The pulmonary reactions is a reason why some patients don't like to take this drug when you hear about this side effect. The pulmonary reactions can be acute and subacute. Now, the acute reactions are going to be more common. Shortness of breath, dyspnea, chest pain, chills, fever, cough, and they may have alveolar infiltrates when taking this drug too long. But the symptoms usually resolve 2 to 4 days after you stop the drug. Acute pulmonary responses are really thought to be due to hypersensitivity reactions to nitrofurantoin. Patients that have a history of responding negatively to this should not be prescribed nitrofurantoin again, because it's thought to be a hypersensitivity reaction. With the subacute reactions, they are rare and usually only occur when you have prolonged treatment. Things like dyspnea, cough, and malaise will usually regress over weeks to months once we stop the nitrofurantoin. So not as fast as the acute, but they will eventually regress. But some patients, though, very rarely, but some patients will actually have pulmonary lung damage that happens. The hematological effects have to do with leukopenia, thrombocytopenia, megaloblastic anemia, agranulocytosis. So if a patient already has hemolytic anemia or any of those hematological problems, you don't want to treat them with nitrofurantoin. Hemolytic anemia may occur in infants and in patients whose RBCs, so red blood cells, have a deficiency of glucose 6-phosphate dehydrogenase, or G6PD. Because of the potential for hemolytic anemia in our newborns, we do not give nitrofurantoin to any pregnant woman that's almost going to deliver, and we're not going to give it to infants under 1 month old. With peripheral neuropathy, this can damage the sensory motor nervous system and can cause a serious concern for this patient. Demyelinization and nerve degeneration occurs, and in this case, it is not reversible. The symptoms that you're going to hear about are muscle weakness, tingling sensation, numbness, and patients need to be informed that if they do experience these symptoms, report them immediately, and we will discontinue the medication. Neuropathy is most likely going to be manifested in patients with renal impairment and that are taking nitrofurantoin chronically. Hepatotoxicity is something that we need to consider too, but it is rare from nitrofurantoin that it's going to cause severe liver injury. What you might see though is hepatitis. They might have cholestatic jaundice, hepatic necrosis, and there have been some deaths that have been linked to the hepatotoxicity of nitrofurantoin. To reduce this risk, make sure that, especially in patients that are on it prophylactically or taking it for a long time, you want to check their liver function tests. And those patients that are showing signs of liver injury, obviously discontinue the nitrofurantoin immediately, and then make sure you chart it and they know that they should never use this drug again. In terms of birth defects, there are some conflicting data of the use of nitrofurantoin in pregnancy. I myself don't prescribe nitrofurantoin for a pregnant woman, and we already know that you don't want to prescribe it close to delivery because of the effects that it has on the fetus. Now, the National Birth Defects Prevention Study, which was published a while ago, 2009, it did show an association between nitrofurantoin and birth defects. There is something called anophthalmia, which is the absence of an eye or both eyes, hypoplastic left heart syndrome, and this causes hyperplasia of the left ventricle and ascending aorta. It is linked to atrial septal defects, and cleft lip with a cleft palate as well. Now, there has been more recent studies, but still quite a while ago, in 2013, that found an increased incidence in birth defects in babies that were delivered to moms who had taken nitrofurantoin. So a second study that supports why I don't prescribe it. And then in this study, though, it did reveal that there's an increased incidence of neonatal jaundice in patients that were exposed to nitrofurantoin in the last 30 days. And this is what supports my reason and me telling you, and the book telling you, that you shouldn't prescribe it to mothers that are about to deliver. So here it's specifically saying about a month before. But however, you cannot predict when a baby is going to be born prematurely. And so if you are choosing nitrofurantoin any time during the pregnancy, and the mom delivers maybe at 23 weeks, 24 weeks, you may run into these same issues of neonatal jaundice and toxicity to the baby. Because of the possibility of hemolytic anemia, we do not give this to patients. It's contraindicated to patients that are at 38 to 42 weeks gestation. There are other antibiotics that you can use, other alternatives, so you don't need to choose nitrofurantoin in those situations. And then the last antiseptic that we'll talk about is methenamine. and it decomposes into ammonia and formaldehyde. And because of this, the mechanism of action is that it denatures the bacterial proteins. This is prescribed as Hyprex or Urex. Those are the brand names. And under acidic conditions, again, it's going to break down into ammonia and formaldehyde. Well, the acidic conditions are the urine, but your urine has to maintain a pH of 5.5 or less. Otherwise, formaldehyde isn't going to be released. Because formaldehyde isn't formed at a physiologic systemic pH, methenamine is devoid of systemic toxicity. So relatively safe. In terms of the bacteria that it's susceptible to, virtually it's all bacteria. There's not resistance to methenamine, and specific bacteria like protease can actually elevate urinary pH because it's splitting the urea to form ammonia. And because formaldehyde is not released under alkaline conditions, when you have infections with urea splitting organisms, methenamine isn't going to help. I use methenamine for chronic infections of someone that repeatedly has recurrence of lower urinary tract infections. But sulfa drugs, the Septra, Bactrim, or the Trimethoprim, sulfamethoxazole, this is going to be preferred over methenamine. But I've had occasions when my patient has been allergic to sulfa drugs and I will use methenamine. And for whatever reason, if they're not a candidate for nitrofurantoin, then I do move to methenamine. Methenamine is not active against upper urinary tract infections because there's not sufficient time for formaldehyde to form for the drug to work. And methenamine is not successful in preventing UTI-associated, catheter-associated urinary tract infections. So what are the adverse effects and the precautions? When you give chronically high doses, it can actually cause bladder irritation, and what your patient will feel is dysuria. Frequency and urgency. We're talking about urinary frequency and urgency. Proteinuria, hematuria. So ironically, a drug that you're using to treat a urological disorder, you can actually cause more urological issues. Because the decomposition of methenamine generates ammonia, right, in addition to the formaldehyde, it's contraindicated to patients with liver dysfunction. Methenamine salts should not be used by patients with renal impairment because of the crystalluria can cause precipitation to the medulate or the hipparate moieties of this type of drug. I do want you to make the connection with the decomposition of methenamine generating ammonia and what the relationship is with liver dysfunction. The drug interactions, the two ones are urinary alkalinizers because they will elevate your urinary pH and inhibit the formaldehyde. So then it's just going to inhibit the antibacterial effects. So patients that are taking methenamine shouldn't be also on alkalinizing agents. We want to keep the urine acidic. Sulfonamides also shouldn't be taken in combination with methenamine because the formaldehyde forms an insoluble complex with sulfonamides. And so therefore it poses a risk for urinary tract injury from the crystalluria. I don't treat patients with diabetes that are on sulfa-derived drugs with methenamine because it's also a sulfonamide. And finally, this last slide here shows you the different types of nitrofurantoin as well as methenamine that you can use. You can see the brand name, the availability, and how it's absorbed, distributed, and the metabolism and excretion.